My name is Will Becker. I'm from VA Connecticut's Prime Center of Innovation and Yale School of Medicine, and the leader of the Pain and Opioids State of the Science and Partner Priorities Workshop. We're calling this a workshop because we do want it to be interactive. We do have a fair amount of information we want to share with you, but then we would like you to process that information and reflect back to us with questions. I want to introduce our panel. We have Dr. Friedhelm Sandbrink, the Director of VHA's National Pain Management Program Office. We think Dr. Drexler may be joining us in progress, but then we also have, going to go out of order here, Fran Cunningham, who's the Director of the VA MedSafe Program of Pharmacy Benefits Management. Dr. Sandbrink and Cunningham, important partners in our work regarding pain and opioids, so very happy they could be here today. And again, Dr. Drexler may be joining us in progress. So Dr. Aaron Krebs, core investigator of CCDOR, Chief of General Internal Medicine at the Minneapolis VA, longtime pain and opioid researcher. Myself, who I already introduced, Keith Humphreys, who's HSR&D Senior Research Career Scientist at the CI2I Center of VA Palo Alto. And then Alicia Heapy, who I believe stepped out, will be rejoining us momentarily, the Associate Director of the Prime Center, also in VA Connecticut. So by way of outline, there's Stefan, thank you. We're going to discuss two main topics: the state-of-the-art conferences that have recently occurred and their recommendations. First, starting with the non-pharmacological management of chronic musculoskeletal pain, SOTA, and Aaron will lead us through that discussion. And then the more recent SOTA, effective management of pain and addiction, strategies to improve opioid safety, and I will lead us through that discussion. While the non-pharmacologic SOTA was a couple years ago, and perhaps the pain opioid results are newer, we thought it was important to present them both together so you get the full picture of the state of the science for pain management and opioids in general. Then Dr. Heapy is going to lead us through a discussion of the organization and aims of the new Pain Opioid Core that Dr. Atkins mentioned in his plenary remarks. And then ending with our partners' reflections on the pain and opioid research priorities that were presented. We will have Q&A throughout the talks, and we will hope that our partners will also, of course, join in the Q&A piece as well. So you don't have to hold your remarks for the very end section. All right, so Dr. Krebs, if you wouldn't mind taking the podium.
Thank you, and I will try to keep this kind of brief so that we can have more time for discussion, and because this is sort of old. So the non-pharmacological approaches to chronic musculoskeletal pain management state-of-the-art conference was actually held almost 3 years ago in November of 2016. It was convened initially with a focus on alternatives to opioid therapy, a framing that I personally dislike because, of course, it suggests that opioids are the primary therapy for everything and everything else is an alternative. The focus was refined to this non-pharmacologic focus. However, we did also look at care management, which spans pharmacologic treatments as well. The goals were to identify approaches that had sufficient evidence. We should be doing this now, and those gaps in the evidence where we really needed to conduct additional research. Since this was a few years ago, I've done a number of briefings on this, and I bet a whole bunch of you have already seen me talk about it or heard somebody talk about it, or maybe you were at the conference. But just to summarize very briefly, we found evidence for a lot of different non-pharmacologic therapies that really have been studied in trials, and VA should just provide to our patients. Those include both complementary and conventional therapies. The evidence supported the provision of multiple first-line therapies. So there isn't one best. We should have options and the ability to step up to more costly or intensive treatments if necessary. And then we did look at delivery models and found there are effective delivery models, mostly that combine case management and decision support to help improve outcomes and direct the right treatments to patients who need them. The research gaps were really about dose, delivery, how to engage patients, how to implement these kinds of therapies and programs. And this is just a slide showing the main types of therapies that the SOTA determined really were evidence-based. VA should offer these things and multiples of these things at all sites so that we have options for our patients. I won't go into depth about this at all. The SOTA also focused on how to deliver these therapies, in part because studies have looked at, individual trials. So we know that there are a wide number of exercise therapies that can be delivered, that can be effective. There are complementary therapies that can be delivered, that can be effective. But how do we get these therapies to people so that they're not just having a shotgun kind of treatment experience where, they're getting sent all over the place in an uncoordinated manner? We didn't find any reviews that looked at how to deliver this care, how to coordinate care for chronic musculoskeletal pain. So we had a review done by the Evidence Synthesis Project, and it looked at some different methods. But just to introduce a couple concepts here, multimodal stepped care, these are buzzwords. Multimodal just means different types of therapies. So for example, exercise and behavioral or psychological therapy and medications. Step care, the idea is, there's first-line treatments, and then if people don't do well with first-line treatments, they should have the option to step up to something more intensive like multidisciplinary rehab, which is obviously a much more expensive treatment and more time-consuming. It shouldn't be the first thing to try. We found in the SOTA that no one approach studied was effective for most patients. Most therapies had similar moderate-sized effects, and patient preferences really matter because people have to participate in this stuff. You can't just say, here you go to Tai Chi and you go to exercise class. People have to have some say in what they're doing if we want them to engage. Collaborative care is a well-established concept in a lot of chronic disease management. It really is team-based integrated care that involves some coordination by a care manager, some kind of point person to help navigate through treatment. This is just a brief summary of the evidence review that I mentioned. They found 10 studies that evaluated interventions to deliver pain care, mostly primary care based. They were all studied over 9 to 12 months. The strongest studies, interestingly, were done in VA. And just to skip ahead to research needs, really the core research needs in this area, non-pharmacologic treatment for chronic musculoskeletal pain, were really about the details of implementing these therapies, not whether the therapy worked at all, but really what's the appropriate dose? So, if you have an exercise therapy, is it good enough to have somebody go once a week for 8 weeks? Or do they need to have 16 weeks? Or do they need to have long-term booster sessions? That kind of question. Delivery approaches, so for what therapies can we do it online or by telephone or video? What needs to be in person, group versus individual? And then importantly, strategies for engaging patients, improving adherence or their ability to stick with it, and maintaining benefits. And then for care delivery models, because what we found was a lot of studies that looked at one model in one site, there was a need for study of multi-site implementation. And if you want to know more about the non-pharm SOTA, we did publish a supplement in the Journal of General Internal Medicine that is available. And I will now turn it over to Will to talk about the more hot off the presses opioid SOTA.
Thanks, Aaron. So yes, Opioid soda was just last month. So in contrast to Dr. Krebs's well-formed ceramic vase of a presentation, ours is a little bit more like a lump of clay at this point. But that is even more crucial, that if, there are things I'm saying, for folks who are at the soda that doesn't quite resonate with what was discussed, or folks who weren't at the soda would like more clarification, absolutely welcome questions and discussion. So the topic of the State of the Art Conference, the title was Effective Management of Pain and Addiction, Strategies to Improve Opioid Safety, VHA Health Services Research and Development Service State of the Art Conference. So this included both the discussion of opioids as a treatment for opioid use disorder or opioid addiction, as well as the use of opioids for the treatment of chronic pain. So a pretty broad swath of topics that we covered. And these sodas are designed to help our research service guide what sorts of studies should be prioritized and what sorts of studies should be funded. So they tasked us with answering the question, where is there evidence sufficient to move to implementation? What important questions do not have sufficient evidence to guide practice and policy, so therefore need more efficacy or effectiveness level studies? And then what issues or new developments are on the horizon that may need to be considered in research, planning, and policy? So I'll just spend a little bit of time talking about the SOTA process to show that there is an intentional effort here to come up with a robust set of recommendations. So there's pre-work involved. The co-chairs, Dr. Humphreys and I, and HSR&D convened a planning committee. We helped refine the key questions for discussion. We identified 3 work groups and their leads. Work group number 1, Managing Opioid Use Disorder, chaired by Karen Drexler and Ellen Edens. Work group number 2, Long-Term Opioid Therapy for Pain and Tapering, chaired by Dr. Sandbrink, Joe Frank, and Joanna Sterles from Montefiore. And then work group 3, Managing Co-Occurring Chronic Pain and SUD, chaired by myself and Amy Bonnert. Important, and something folks should check out if you haven't seen them yet, the Evidence Synthesis Program from Portland performed rapid evidence reviews on a key question for each of the work groups. I believe we're going to circulate these slides after the presentation, but I have web links to the 3 top reviews that the ESP performed for each of the work groups, and they're really well done. So in terms of the pre-work leads up to a day-and-a-half conference. Again, that occurred last month right here in DC. On day 1, the work group leads facilitate discussion to address the key questions that were identified. The work group together comes to consensus on priority research agenda, policy recommendations, and implementation strategies. And then they develop a summary of everything they came to consensus on day 1. So that's more or less with each of the work groups working independently. Then on day 2, all 3 of the work groups come back together. They present their work group summaries to one another. There's an opportunity for clarifying questions and discussion of those summaries. And then there's a panel of stakeholder operations and policy leads who react to the work group presentations, and then a large group discussion of the next steps. So now I want to go through work group by work group, what was discussed and what came out of the SOTA as primary recommendations. So work group 1, and reminder, this was the Managing Opioid Use Disorder work group. One of their key questions was addressing barriers and facilitators to implementing MOUD. And I want to, MOUD stands for Medications for Opioid Use Disorder. The prior term would have been medication-assisted treatment. There's a recognition that that term itself is probably not perfectly apt, because the medication itself is what's perhaps the most important part of the treatment. So to call it medication-assisted treatment is a bit awkward. So medications for opioid use disorder, and here we're talking about buprenorphine, we're talking about methadone, we're talking about injectable naltrexone. So where work group 1 saw there were knowledge gaps, need for more research, was to understand how the barriers and facilitators identified by the evidence synthesis program applied to the VA, and I'll show you what those were in the next slide. And secondly, understanding how to intervene on stigma. So we know there's perhaps 10% of patients in our system who have opioid use disorder who are accessing treatment, 10 to 20%. So that's a huge treatment gap for this potentially life-threatening disease. And one of the main drivers that prevents people from accessing treatment is the stigma that they are perceiving from their communities, from their healthcare providers, maybe even from themselves. And how do we intervene on that? So policy and implementation recommendations, things that are ready to happen now, remove special privileging to get your DEA X waiver to prescribe buprenorphine. And that has actually already taken place. So in the last couple of weeks, a high-level memo came out saying facilities should no longer require special privileging to have a provider use that medication. Use of clinical decision support at the bedside, if you will. Clarifying policy related to misperceived barriers. There's at the facility level, there are a number of barriers that you'll hear that are getting in the way of accessing medication for OUD, and making memos and other updates to make sure that those barriers go away. And the example I just gave was an important one. Incentivizing medication for OUD treatment, meaning incentivizing providers through pay for performance, for example, to provide this treatment. Removing barriers to teleprescribing, which we know from Mark Rose and David Moore and others can be a highly effective way of reaching veterans who have difficulty coming to the main medical center. And then access to all formulations of medication for OUD. Buprenorphine seems to be the major push, and that's an important push, but methadone should still be considered a high-level evidence-based treatment, and when that is needed, veterans who need access to it. Same for injectable naltrexone. So here's the long list of barriers and facilitators identified by the ESP group. I won't read through all of them. Patient level, provider level, system level. You know, if you're a researcher in the audience and you're thinking about an implementation project, you would propose attacking some of these barriers would be, you know, essentially what the field is saying we need. One or multiple of these barriers. Work group 1's second question was, what is the minimum monitoring necessary to feel that we are delivering evidence-based care in a safe and effective way? You know, there's sort of a balance here. There's concern that if you make monitoring too onerous, you're going to drive people away from treatment. But of course, you have to have some degree of monitoring to know that the therapy you're delivering is happening and it is safe. So a new sort of buzz phrase in the field is measurement-based care. You know, in other disease states like diabetes, we can follow the A1C. There's a number of different measurement-based care proposals coming from CMS and other places. How can we follow the progress of our patients' role in the addiction disease course, and how should we apply that in our system? How much drug use monitoring do we need to do? What are the, you know, minimum threshold, especially at initiation of treatment, and then as patients stabilize? Frequency of clinic visits, the role of technology, extending the clinic visit to a virtual setting, allowing patients to have a visit count, even if they don't show up to the facility. And then, of course, from a policy standpoint, providing guidance on the minimum standards that I just went over and clarifying expectations of urine drug screening. Their third question was comparative effectiveness of psychosocial treatments for MOUD. So while the medication is perhaps front and center, it's clear that the adjunctive psychosocial components additionally improve outcomes. So the knowledge gaps recognized were comparative effectiveness of individual versus group settings, utilization of community supports, both peer support and family support, which we know are both critically important in recovery from substance use disorders. Impact of the methadone maintenance structure on comparative effectiveness of psychosocial treatments. Can primary care integrated mental health be a facilitator to getting access to medications? And could we optimize training? One clear policy recommendation is that it should be clarified nationally that psychosocial treatments are not, should not be a barrier to receiving medications for OUD. They need to be available for veterans who need them, but it's not required that every veteran to access medication should undergo psychosocial treatment. And then supporting implementation of contingency management. And then work group 1's fourth question, how to sustain engagement in MOUD treatment. So we know this is a chronic disease, and to do well, patients need to stay in treatment long term, and we need to support them in the pursuit of long-term treatment. How do we implement chronic disease management for MOUD like we do for diabetes, asthma, and other similar chronic diseases? Understand why people are discontinuing, dropping out of therapy. On the flip side, what are the necessary indicators to consider stopping MOUD, say when the patient's been on therapy for 2+ years? Is it advised even then? Can technology facilitate sustainment in care or re-engagement in care when a patient has fallen away? So policy level, again, efforts to re-engage early dropouts from therapy. Could there be expected reporting and follow-up on overdose events that happen? You know, if let's say I'm prescribing a patient opioids and they have an event, an overdose event that comes to the emergency department, there's no automated way that I hear about that, which is a real quality of care problem. And then can we leverage lessons learned in terms of longitudinal follow-up of patients from suicide prevention work? All right, now jumping to work group 2, and this again was long-term opioid therapy for pain and opioid taper. These were the sort of 5 principles that this group said, these things are consensus, evidence-based, ready for implementation. I'll try to speed up through these a little bit. Avoid initiation of long-term high-dose opioid therapy for pain, recommending individual assessment of risks and benefits, and individualized implementation of opioid dose reduction. Recommend ongoing assessment of opioid use disorder and referral treatment when opioid use disorder is evident. Again, this is among patients prescribed opioids for pain. Recommend system-wide access to team-based support for opioid tapering, including engagement with the patient-aligned care team resources. We cannot in 2019 be even thinking about situations where we are cutting patients off from opioids unilaterally without discussion or support. We need to move past that as a learning healthcare system. Support programs that provide intensive multidisciplinary treatment to support opioid dose reduction or taper. More research needed. What are the benefits and harms of opioid dose reduction and discontinuation? You know, there's been a belief that it's generally speaking a good thing if the medication isn't helping the patient to slowly reduce it. But we need studies to show whether and to what degree that's true. Benefits can be improved pain severity and pain-related function, quality of life, and patient satisfaction. But harms are important to consider and are becoming more apparent, especially with the unilateral tapers that are quick. So harms could be overdose mortality, depression, suicidality, and others. And how does tapering impact healthcare utilization and retention in primary care? Of course, harms and benefits of tapering, but also how do we do it more safely and more effectively? And I won't read through all the different potential potential ideas for how this could take place, but this work group came up with a number, and again, this is a nice roadmap for how we might think about next steps in research. There was still discussion among work group 2. Is there any role for long-term opioids for chronic pain? And a particular scenario that was raised among veterans 65 and older, what are the benefits and harms of low-dose intermittent opioid meds compared to non-opioid meds, especially when other analgesic options are limited in this segment of the population, including a discussion of the role of buprenorphine for chronic pain, which may have a better safety profile than some of the other opioids. And then from an observational standpoint, what are the characteristics of patients for whom the benefits of low-dose intermittent opioids outweigh the risks? All right, so then lastly, work group 3, what we, in terms of what was ready for implementation, we recognize, and this was co-occurring, patients with co-occurring substance use disorders and chronic pain. There's good data for behavioral interventions for chronic pain among patients with SUDs in terms of improving pain outcomes. A sort of suite of psychological interventions, CBT, ACT, mindfulness-based stress reduction in patients with both conditions in specialty SUD settings. Also that we've seen benefit for exercise and movement therapies for pain generally, and then feasibility studies for patients with SUDs. So we didn't think this was quite ready for implementation per se, but we thought hybrid effectiveness implementation studies to understand, can these combined treatments be used in primary care within current VA care models? What should be the relative weight of pain versus addiction content in this co-occurring population? Who can deliver these therapies? How to combine modalities of behavioral interventions with medications? What are the moderators of effectiveness of these treatments? How do we increase their effect sizes and improve veteran engagement? And how can we deliver them in modes that improve access, for example, tele and virtual health? Other areas in the co-occurring realm where more research was needed: what is the effectiveness of buprenorphine for chronic pain compared to placebo or other analgesics? And this we would think of as a step-up therapy, you know, people who are on non-opioid analgesics. Is there a role for using buprenorphine? We already have evidence of some formulations, transdermal and buccal, for this stage, but like the full agonist opioids of the 2000s, they haven't been tested beyond 16 weeks. So really, what is the benefit of buprenorphine in a pragmatic pain study? And then buprenorphine or naloxone versus alternative taper strategies once tapering from long-term opioid therapy is indicated. And we were talking about a potential adaptive study designs where patients who are initially not offered buprenorphine, if they don't tolerate a standard taper, will then be re-randomized to potentially receive buprenorphine. And then our group's evidence synthesis program report was about managing acute pain among patients on medications for OUD. So as we expand access to this medication, and hopefully more patients will get on them, they will still experience acute pain, and how to manage that. The ESP summary found that actually continuing buprenorphine or methadone after surgery or trauma may reduce the need for additional opioids. Also a recognition that patients with OUD on medication-assisted therapy are opioid tolerant and may need higher doses of opioid agonists for effective pain control. Ineffective pain management of acute pain in opioid use disorder patients taking methadone can lead to disengagement in care. And this could be in the inpatient setting. If the patient feels like their pain is not managed well, they may leave against medical advice and may never be seen from again, which is a major quality of care problem. And then future research needed to evaluate effectiveness of adjuvant non-opioid pharmacological and non-pharmacologic acute pain management strategies for patients with OUD taking methadone and buprenorphine. And that same statement could be repeated among all patients facing acute pain, whether or not they are on medications for OUD. Other cross-cutting and emerging issues that came up, including patients with SUDs and trials of pain treatments whenever possible. Traditionally, those patients with SUDs have been excluded, so we don't have a very good pragmatic view of how effective these treatments can be. Avoiding age cutoffs in our studies because we want to be able to inform CMS policy with our work, and we also want to be able to inform the care of our own patients. Consider potential SUD-related harms of emerging potentially problematic pain treatments, cannabis, ketamine, and gabapentin for pain. And then one that came across all three work groups, is there a need for a new diagnostic entity? Some authors have proposed the term complex persistent opioid dependence, and this is meant to recognize the gray area where not sure there's fully diagnosable OUD. There's limitations to the DSM criteria in the context of long-term opioid therapy. And is this an opportunity to use a Delphi panel of experts to help define criteria for this potential condition? And DeSoto was a lot of work put in by a number of experts, and I just wanted to acknowledge those folks and their strong work over those last 3 months. And with that, I would like to turn it over to discussion about both the non-pharm soda and the pain and opioid soda as well. Sure, please.
So I noticed in peer support as a gap. What are you guys doing to incorporate peer support into that so you can take that gap, actually prove that it works, and then all of a sudden I can start feeling better?
Repeat the question.
Yeah. So the question was, we had acknowledged peer support as a gap in our studies, and what are we doing to fill that gap, basically. I can speak about one. We're developing a mobile app to help veterans who are interested in tapering their opioids do so. And part of that app is the opportunity to get connected with another veteran who has gone through opioid tapering. So a peer support specialist to work one-on-one with that veteran in the way that peer support can be very effective. Oh, that's great. That's great. And so I'm sure other folks in the audience, any other experience with peer support interventions? Some nods, yes. Want to tell us about them?
We have a peer support intervention for veterans who are in incarceration. And back in
People online won't be able to hear that. I can let me run a microphone over there too.
Okay.
Maybe. Okay. All right. Question over here.
We have an intensive peer support that we've added to the Healthcare for Reentry Veterans program that works with veterans coming out of incarceration and pretty much helps do whatever needs are met. Ben's also in the room, so he's going to tell you that there's some peer partners involved in the whole health system. So there's a lot there as well.
Great. Thank you. Other questions, comments, discussion? Sure.
I didn't get my jog this morning, so this is going to be it.
I was just going to mention that the new Mission Act has peer specialists put into primary care in 30 VAs across the country, and those folks will be doing all kinds of work, including that kind of support for folks who are tapering and working with addiction.
Great.
So then the first 15 sites have launched. So,
Cool.
yeah.
Fantastic.
I asked how many peer supporters that is?
2 at each site in primary care.
Well, they'd be like 30.
And
And that's probably even underestimating the amount.
Yeah, you have to start somewhere, but
Oh, I get that.
yeah.
I'm just throwing out to you guys that you need to, I think, first you need to work on getting more peer supporters in the system.
I would
That would save money on both ends.
Yeah.
Paying them and then the money you guys are gonna save on those added costs and something like that.
So- I'll get you in a second. So, Joe, you had something.
Yeah, a related issue, I think, is veteran support and veteran guidance of the research to address the research gaps. And so I'll mention one project, which is a consortium nationally to improve medication treatment of opioid use disorder, which will be supported by multi-site National Board of Veterans to provide guidance, advice, support to the researchers. So hopefully that helps us ask and answer the questions with veterans' input from the very start.
I mean, I think one of the most important things you said, Will, or whoever said, maybe it was Aaron, was the stigma issue. And well, I don't remember what the number was, but 13% or some incredibly small number of people who need to be in STD treatment are. And I think that's where potentially, although we don't know this yet, the role of the peer can be just indispensable. And so one of the things we're looking at is peers out in the community, not just inside the VA, but whether it's in the Y, it's in vet centers, et cetera. And so we're starting to really try to look at that and building partnerships with VSOs and other places so that it's not all about you have to come to the clinical encounter and get the label. You can be working with other people who've been through similar things. And like I said, we don't know how that's going to work yet, but I think that's hopefully going to be something we partner with. I mean, we're already partnering with, the Boston Bedford query on that, but hopefully more people will get interested in the impact of that on STD in particular.
Great. Thank you, Ben.
I'm just asking a very inexperienced question. I'm one of the VA veteran advisors from Minneapolis that was so graciously allowed to attend the event, and I appreciate the opportunity to be here. My general question, though, is particularly for the opioid tapering project, the idea of an app to bring it more, centrally home and 24/7 kind of thing is I think a really good idea, but my broader question is it's human nature to think that if we're losing something that we're not going to have the same effect. So how do you use these alternative, more homeopathic things to replace what we believe is being lost with the tapering of an opioid? And I think it's got to be greater than, just an app. And for most folks, it's not necessarily even, I think, the stigma of getting to the VA. It's the distance and the logistics of getting there when, you're also working or trying to raise a family or deal with family and stuff like that. So, how do you implement this alternative so that mentally people believe that they're not losing anything with the taper, but are still, finding something that's effective? So how do you push it out to the community, whether it's easy access to exercise, yoga, Tai Chi, whatever? And then I was just a curiosity question. Is there an age that is more susceptible to the opioid use disorder that you're finding within the VA? It's just a curiosity question for me.
Yeah, really great comments and questions. So to address your first question about if we're taking away opioids, how do we support with other modalities? And that's a huge issue. I'll just speak for the app itself, which is of course not only one of many projects. We've got different silos on the app. Little but you can click for, here's a stress reduction. We actually show videos on how to do mindfulness-based stress reduction and abdominal breathing. We've got another one on how to engage in structured exercise. So we're trying to incorporate exactly the things that you're saying, but will it equate to meaningful use? How do we really get the veterans the services that they need and will help them through this process? I think the answer is to provide it in whatever format they can access it. So if someone wants to do it online, they do it. If they rather come face-to-face, get them a face-to-face appointment and get it somewhere close to where they can really access it rather than having to have them drive an hour and a half to the medical center and then circle for parking for 20 minutes. So really, really important points. And I'll turn it over to the other folks for other comments, but just about the prevalence of opioid use disorder, it runs the age spectrum because we see, young adults who started experimenting with prescription opioids who may develop an opioid use disorder in their late teens. And then we see folks who were exposed to opioids through even pain treatment later on in life who are developing opioid use disorder into their 60s, 70s, and 80s. So it really is a broad swath.
Yeah, so I just like to give a little bit of perspective from our National Pain Program in this regard. And before I do that, I want to thank, first of all, everybody here, the panel and the audience. I think these are incredibly helpful questions for all of us to understand. And I think there's so many that we collaborate with to do this. Now, I want to go back a little bit to the VA DoD Clinical Practice Guideline that was published in 2017 that addresses maybe some of these concerns. And it really is it was the first guideline actually that was developed with veteran input. We had a focus group, right, that brought veterans on board and says, as the subject matter experts discussing what is best evidence based on the literature, we had a separate group, which was an engagement with group of veterans trying to get their impact about the issues, anything related to opioids, long-term opioid therapy, including tapering. So I want to highlight that. In general, I think all of us in VA realize that the veteran's voice is so important. And I think that is well recognized by VA leadership. I can't speak for them, but we hear constantly from leadership top down how important it is to increase, to be aware of what the veteran's perspective is, both veterans within the system, but also through the service organization. Among others, we in the National Pain Program for the last year have been working very closely with the Veterans Experience Office, right? We've had meetings every other month with them. We know about their V-Signal, which is a new approach of measuring the feedback from veterans that is available now. They're collecting the feedback. I think it's 65,000 data points that come in every month with the veterans' perspective. So I think that needs to be increasingly utilized to inform us to deliver better care. Just coming back also to the VA DoD Clinical Practice Guideline, I just want to highlight two of the recommendations there. One is the awareness of how challenging it is to reduce opioids once somebody on it, but at the same time, and Aaron, you can talk more about it, the realization that in the long run, opioids usually don't help. So that leads to the first recommendation of that VA DoD Clinical Practice Guideline to not initiate new patients on long-term opioid therapy without a really good rationale or justification for the occasional exception. Because it's much better to get patients not on there rather than dealing with it afterwards. And there was no recommendation in there that all patients have to be, tapered off of opioids. In fact, it emphasizes already in 2017 how individualized taperings have to be done. And if you look at that HHS, the Department of Health and Human Service guideline that just came out last month, it actually adopts the language from the VA DoD Clinical Practice Guideline and the tapering tool we put out more than 2 years ago. Being patient-centered, very careful, deliberate if you make adjustments to go very slowly. The other thing is that they talk specifically about the concerns of developing opioid use disorder in the younger veteran. So along the age below of 30, I think we all realize that that's a particular concern. I just want to bring this in as some of the answers to the questions that have come up.
So I think we'll move ahead and Dr. Heapy, come tell us about the Pain Opioid Core.
Hi, I'm Alicia Heapy. I am a researcher located at the Prime Coin at VA Connecticut. I'm one of the multiple PIs of the Pain and Opioid Consortium for Research, or CORE, along with Aaron Krebs and Will Becker. So the HSR&D funded Pain and Opioid Core is really designed to do one overarching goal, and that is enhance collaboration and accelerate research and dissemination within the broad area of pain and opioid research. So we've kind of organized the core around 3 themes, with each PI being in charge of a theme. My theme is behavioral and self-management approaches. Erin Krebs' theme is pain management interventions and care delivery, and Will Becker's theme is long-term opioid therapy, opioid misuse, and opioid use disorder. So this is kind of a very brief schematic that shows the themes and the PIs in the center, but supported by a number of different stakeholders. So we have an executive steering committee that includes our partners that we will work with and who will advise us, an internal leadership committee and co-investigators who are the VA pain research community that we'll work with, a veteran engagement panel that will advise us on priorities from the veteran perspective, and a dissemination committee. We're supported by coordinators in each of our sites, and we'll really work to enact the work of this core through strategic priority area or SPA work groups. So I wanted to acknowledge members of our internal leadership committee. These are senior VA pain researchers who we'll meet with regularly, both in teleconferences and in person, who will advise us on the development and enactment and refinement of our strategic plan, which I'll tell you a little bit about in a minute, and will help us identify priority areas and make funding decisions and really do the work of our core. These are our co-investigators. These are really VA investigators with expertise in pain research that are meant to really represent the diverse subtopics within the broad area of pain and opioid research. And then our partners, many of whom are here today, Dr. Friedhelm Sandbrink, who's the director of VA's National Pain Management Program Office, Dr. Ben Kligler, who's the National Director of Integrative Health and Coordinating Center, Dr. Karen Drexler, National Mental Health Program Director for Substance Use Disorder, and Dr. Fran Cunningham, Director of VA MedSafe and Pharmacy Benefits Management. We consider these 4 partners kind of our founding partners, our most critical and collaborative partners. We plan to branch out beyond these partners after we get started. So what is our strategic plan? How will we move on from the recommendations that were made in the SOTAs that were discussed today to really enact this research in the VA research community? So when HSR&D put out this RFA, they said, we want you to do 4 types of activities, but they let us choose how we would do those activities. So I'm going to tell you a little bit about what we've proposed, with the idea that in this first year, we also said that we would work to refine these priorities in conversation with our stakeholders. So, for example, in terms of supporting portfolio review and further refining priority areas that were already identified in the SOTA, we're working with contractors to identify funded pain-related research by VA, NIH, and PCORI, both to identify gaps, but also create a searchable repository that can be a resource for investigators. We're going to conduct a Delphi study to select the core priorities from among what was found in the SOTAs and additional work. This will give us a systematic way to decide together about what the priorities of the core are. That will be with the investigators, partners, and veterans involved. And we'll also go on to propose evidence synthesis program projects or reviews. We aim to develop and further cultivate partnerships with our external partners, but also with veterans. We're developing a core veteran engagement panel that will not just give input to the core's priorities, communications, and work, but will be available for core-affiliated investigators to get veteran input on their proposals, on their recruitment information, on their messaging and dissemination. We're working on building a research network. So as I said, we'll have priority work groups. We're also planning to fund rapid pilot projects. So we have about $150,000 in year 1 and in year 2 to fund pilot work in identified priority areas. we'll work together to identify tools and interventions that are ready for wider implementation. As something that really came out of the SOTAs, is we have a lot of evidence-based approaches and tools that really should be in wider use. And building mentorship resources for early career researchers. Finally, with disseminating impacts, we propose that each year we would select a particularly high impact study or finding and develop an integrated communication package, meaning there would be communication targeted at other researchers, but also partners, clinicians, patients, and the general public. Finally, something that we're really excited about is we think that we're going to be able to partner with the Op-Ed Project to provide interested investigators, possibly up to 20, with day-long training from the Op-Ed Project about how to write op-eds and get our work, our opinions, our knowledge out to the public more effectively. It includes a day-long work group plus mentoring from a journalist for 3 to 6 months post. VA does a lot of good work, and I think it's the finest pain care anywhere, and no one knows that. So this is our strategic plan. You can see we have benchmarks, we have impacts, we have deliverables. We kind of said what we would do each quarter. The idea really here is this first year we're still refining with our stakeholders. One thing you'll notice is we kind of start off in the traditional VA way where we propose teleconferences with our groups to start things off. However, we were counseled against this by Becky Yano, who many of you know, who has really developed the Women's Health Consortium, where she suggested we might want to try individual interviews with our partners and investigators to really have a chance to get more detailed information from the field. So that's what we did. We conducted 30-minute interviews. We were able to talk with 23 of our investigators and all 4 of our partners. We really want to thank people for taking the time to do that. I know everyone's very busy, but the thoughtful comments and really potentially actionable suggestions were very important. So we asked some very basic questions. What do you think the Corps can do to be helpful to the VA research community, and what do you think of what we proposed? And then for our partners, we asked, what are your priorities for the Corps, and how can we interact best with you? I want to say this is not a formal qualitative study, but things, as they often do, fell out into 3 buckets. There's really process, which was a lot about researchers talking about the barriers to the research enterprise and the process, and how possibly the Corps could help. And then really prominent areas of communication, the need for it, and some concrete suggestions, and then how research can be supported with some concrete suggestions. So I would say overall people say there's been a huge interest in pain and opioid research. People are busy, people are well funded, but people are worried that their capacity to take on new work in this very important time may be limited by inefficiency in the system, in the research system. So it's hard to do research. Information is not centralized. Oftentimes people feel that they're reinventing the wheel, trying to figure out how to do something. How can I send text messages to patients? How can I use REDCap to collect surveys? These are our perpetual questions. Oops. There's a need to bring in new investigators, both early career investigators and maybe more seasoned investigators who work in different areas. And also potentially a time that we could maximize the value of already completed work. So I think that there's a lot of work out there that could be developed that we didn't disseminate as effectively as we could, that we could examine for themes that span projects and work so that we can put it out there and potentially achieve greater impact. People want to collaborate more beyond those who are just in their immediate area or those who they've traditionally collaborated with. We're being prompted to increase the impact on the health system of our work. but many investigators aren't clear exactly how to do that. Our enterprise is centered around presentations, papers, and grants. We don't often have the training or the structure to produce impact, though we want to. Possibly through the core, we can have that, that critical mass to do more impactful communication. People were positive about work groups, but caution that, of course, even good things can go wrong, and many of us have seen work groups go wrong. So the advice there was there should always be a defined product that the work group is working towards. It should be supported administratively. And instead of starting out with a lot of standing work groups, potentially have a very small number of standing work groups and then successive work groups. This work group will write a paper. This work group will create a dissemination package, and then it will go away and a new work group will emerge in its place. There were a lot of comments about unknowns related to Cerner. Will we be able to access our data? What data will be available in an electronic health record, and how will that change what we do? So second bucket. Second bucket was about communication. People want more communication, not just with other investigators, but with partners, patients, clinicians, VISNs, funders, Congress, the public, and ideally this will be bi-directional. There was a lot of good advice to set very explicit expectations for the core. So develop a clear message of what our mission is, what we do, and what you can expect from us. And finally, could we potentially serve as a conduit for information about the Cerner transition? There were a lot of suggestions for developing methods for easier communication, newsletters, social media, listservs, portal, CIDR. There was also, I thought, some very good advice about synthesizing findings across studies or even within a study. So avoid a blast of information to clinicians, other researchers. Really take the time to synthesize and develop practical recommendations and action steps, especially when communicating with clinicians and patients and the public. And then also try to look across themes to identify how we can make more impact. One of the investigators I was speaking with in a different area said that in their de-implementation query, they had found that patients are very reluctant to give up low or no value interventions when there's no alternative, right? And that represented important knowledge that they could use to think about how to communicate with providers so that they could talk to patients meaningfully about that, and messages that they could send to patients. So I think we probably have a lot of those types of things that we could develop. And then finally, use communication to develop demand from the clinical side. There are a large number of large multi-site trials going on in VA right now. We're pushing into a lot of clinical centers to do research. We want patients to engage, and we want clinicians to help us do our research. But we haven't created the demand. So we're pushing, but there's no pull, right? And so potentially, using community of practice, using veteran stories, we can promote the idea not just of specific studies, although we should do that, but about research in general and how it can be helpful and how it has helped people. Okay, and then in the bucket of research support, not surprisingly, rapid pilot funding was the single most popular item suggested. People had a lot of ideas about mentoring. Could we do pre-application grant reviews for CDA applicants? Could we create a formal mentoring group that met quarterly? Providing support for researchers who are not located at COINS, and providing also implementation training. Implementation is incredibly important. VA, HSR&D has fellowships in women's health, in informatics. Could they have a fellowship in implementation to develop the training in that very important area for us? There was a lot of interest in new and emerging areas of research, some of which Will and Erin have already mentioned, and I won't go into the details of that because I want to keep on time here. There were all manner of suggestions for shared resources and consultation services. So could the core help us find consultation for subject matter expertise, stats and informatics? Could we review grants? Could we hold a code bank that all of us could use? Could we provide a repository to understand data collection methods and how they could be used in VA? Can we text patients? Can we use electronic surveys? Could we develop a wiki similar to CFR? And could we have repositories so that people know where to find things like grant writing resources, recruitment materials, common assessments, and data elements? And then finally, there was a lot of discussion about how do we implement our practices. So a lot of investigators want to implement their work more widely, but we're not trained in that, and it's not always clear the best way to do that. So could we set up a pipeline to the VISNs, help people understand how to work with VISNs, identify pathways that were used in the past, and work with the new Query Center for Evaluation and Implementation Resources. So that's a lot. Obviously, we cannot do all of that. But I think it's good to get everything on the table to see what the universe of possibilities are as we discuss those things and move forward, realizing that we're foregoing some things, but we're identifying what we feel as a group are the most important things. Efficiency, synthesizing information, and promoting communication and collaboration really came through as, I thought, the most important things. We'll be having 2 upcoming calls to discuss this in more depth. I'm going to give you a couple of pieces of information about that in a couple slides, but I did want to mention what we got from our partners. So we interviewed our partners. They told us that their priorities for the Corps are to continue to participate in the development of our strategic roadmap. They really emphasized the need for rapid, widespread implementation work. They suggested additional partners that we would want to work with. They want to participate in drafting RFAs for future work. And they reminded us about the help that they can provide in terms of disseminating findings. So they are involved rather intimately with clinical program leadership and frontline clinicians. They can help us to do things like develop decision trees or support tools that can be incorporated in the medical record, promote patient and provider education tools or public health messaging, and get us onto a community of practice calls and in touch with clinical leaders who could potentially carry out the implementation of what we find in research. A few priority areas, I think this echoes some things that we've heard before: more investigation of specialty care and primary care coordination. Evaluation, so CARA mandated care teams have been implemented, but we don't know their effect on the care quality or pain outcomes. Functioning after opioid taper, evaluate clinical pharmacy specialists, clarification about opioid dependence versus opioid use disorder, combining and sequencing of therapies, expanding capacity for research, and adopting common assessments. So, few upcoming things. Tomorrow we have a breakfast meeting for the Corps. If you're interested, it's an informal meeting. We would love to see you there to continue this conversation and to talk about a couple steps forward. Next week on Wednesday at 1 Eastern, we'll have Pain Research Working Group. We'll continue to talk about this, hopefully have a little bit more time for discussion and solicitation of even additional ideas. The week of November 18th, we will be starting, we hope, our internal leadership and co-investigator teleconferences to kind of build on this initial bit of information that we have. Okay, and that's it. Okay, so can take questions. Thank you.
I won't scare you. I get pretty passionate sometimes, so please ignore my passion. But in the aspect of veteran engagement, and you said you had your internal leadership. To me, that when I saw that list, that seems like it was all docs and academics, and I'm really into that veteran engagement side. I really believe, in my mind, and I'm just going to say it's my mind, that there should be veteran engagement at every level of that leadership, all the way down to the basic thing. So that's something that Corps has thought about, and
decided not to implement, or are you really considering on implementing, allowing that veterans engagement into that whole process?
So in the schematic, and I might not have highlighted this properly, so we are developing a veteran engagement panel.
But that's not what I'm talking about.
And so let me explain, and then I want to hear so you can give it. So as we make our decisions about our strategic roadmap, veterans will be involved in those decisions. We want veteran input on our priority areas and how we go about doing those things, especially as it touches the veteran. One of our impacts that we've proposed is that we will increase veteran input across projects that are proposed, dissemination that goes out, and priority areas. So we want to, so when we have in-person meetings, the veteran engagement group will be there. We will meet with the veteran engagement group separately, and we will offer the veteran engagement group as a resource to investigators who are affiliated with the Corps. Bring your ideas to this veteran group and get their input before you go forward.
So I get that, and I'm all for that. But again, I'm going to go back to that whole thought pattern of the inner leadership group doesn't have a veteran representative in that group, which to me, in the scope of real true veterans engagement, as a veteran and kind of engaged in this kind of stuff for a pretty long time, to me sounds like that would be really key parts of that engagement, where not only you have your group for the more I can't think of the word right now, but a resource of lived experience, for lack of a better way, because I can't think of the other word I was thinking of at this point. But then yet, though, in the scope of the leadership, that there's also that veteran engagement that keeps all the PhDs and MAs and whatever other degrees that are behind people's names on track. And it's more transparent, because now you got veteran engagement, and it's not that we don't trust you guys, but more veteran engagement and more transparency would be really cool to alleviate some maybe pushback from the veteran side of things. I mean, that's just a thought. I would, if I was in charge, I would do that.
I think that makes sense in terms of the synergy that when someone is in the room at the time, they can better contribute and shape, rather than everyone will come together, which is kind of what this shows, later. What you're saying is it's better to have the veteran in the room right from the beginning.
But still keep that core group.
Yes,
Those
yes.
experienced folks there to just enhance what you're looking for. But I personally would believe that it would alleviate some transparency issues and a whole bunch of other, like these politics of how the veteran community can get kind of political in some cases. It would alleviate some of that stuff. Because they feel that they're represented through the whole chain, and then they also have their group, that actually the idea group, and that's what I would call it, an idea group.
Right. And it's more likely to resonate with the people that we want it to resonate with.
Got a question over here.
Well, both. So I wanted to tag on to what he said, because we do something vaguely similar with our group. So we have a veteran engagement panel with our COIN, but then a person from there is at our expert and stakeholder, or whatever it's called, executive and stakeholder steering committee meeting. So that might be a simple way to incorporate somebody from the veteran engagement group in your leadership. My question was, how are you recruiting people for the veteran engagement panel? Is this nationwide? Is it going to be virtual? Like, what's your plan there?
It is going to be nationwide. We're talking about it tomorrow at the breakfast meeting. We'll be asking investigators from each of the sites to nominate, and we'll be giving you recruitment materials. I think maybe Erin can say a little bit more about this, because we're really basing this on the method that she's developed in her prior studies of getting together a very functioning veteran engagement group.
come tomorrow morning. Get up early.
We actually have, I should just say, I was really interested in this part of it is that we work with a group from the University of Wisconsin that will train investigators to use and communicate effectively with veterans. And veterans, they'll be given some training about research so that we can more effectively work together and communicate. So,
just wanted to build on what was being said before about, you know, veterans and having them inform the work that you're in trying to help you out. So there's plenty of folks that, you know, beyond the lived experience, I'm a social worker. There's folks that are going back to school. There's folks that are in medical school. I know a kid that was an 0311 machine gunner that went to Dartmouth and now he's at Johns Hopkins. I think about the doc that ran the Boston Marathon and then felt like he had to go to MGH. You got a feeling, and then he's the JSOC surgeon. He works for Joint Special Operations Command, and no one in the ER had ever dealt with blast injuries, and so when they presented, he was there and he knew how to deal with them. So there's folks that, you know, pertinent to what you're trying to do, you know, that are both prescribing opioids to folks, you know, on the line when it's, you know, they're giving us stuff when we're downrange so we can drive on and continue the mission. Track those folks down and talk to DOD, because I don't think people are talking to DOD enough. The folks that I was on the line with that were colonels are now 3 and 4 stars on their shoulders. I get calls from them about, we just had someone that died by suicide and I don't know what to do, and then giving them the answer and saying, sir, you can't call me. You have to know these things. Your staff have to know who to reach across the aisle to and talk to, and be, hey, we're not doing a good job of it. I work in 10 RCS in Baco for readjustment counseling service for the vets in a program, and we're hitting it hard right now, and we're still not, you know, doing as much as we need to be doing. And I think that's universally across the board. But to your points are about abdominal breathing and everything. Every single member of the armed forces knows how to do abdominal breathing. That's how we qualify on our assigned weapon systems. But to this gentleman's point, you know, use veterans to leverage to provide that visibility on stuff that we know that you all don't know, and you can't know unless you've done it. And even if you have done it, you won't know everything. So use the folks that want to help each other out. The last thing I'll say is that communities where I've witnessed this type of success from the limited time, I've only been in VA for 6 years, but the Native American communities that we work with, and Justine's heard this so many times, but specifically the Mohawk, you know, I've been allowed into that community, and the way that they heal, the way that they sort of pile on with folks that are, you know, struggling with there's a tremendous amount of narcotics traffic that comes through Canada, through their community and into the United States. The way that they go about doing things across the board is exactly what we should be modeling off of, in my estimation. And yet we've got, you know, OTGR that's got one person that has 14 nations that they're responsible for, from the Midwest out to the East Coast. That's impossible. Impossible. How do they do it? They've got like 4 people in OTGR. It's crazy. So I mean, if we were able to connect the dots on this and get the constellation, we can start figuring some of this stuff out. But you're on the right track.
Yes, I'm very interested in the conversation about the veteran engagement in the National Healthcare for the Homeless program. There was a consumer advisory board, and that still exists. Then eventually consumers just joined the board, and it was sort of a normal thing that it was like, oh yeah, well, this is working, and that is going to help us. Related to that, I think we should realize that in the pain opioid space, we have this very interesting population of veterans who should be of great concern and crucial to engage both in our clinical care and on our design of research, which is veterans who have fled the VA. So in this space, there is, you know, only, you know, thousands. There's actually one, we just looked at 1,700 person Facebook group of people who have come to feel that their pain was itself a stigmatizing experience in the VA, and to either use Choice Act, which is what the VA paying the dime, to go elsewhere, or to just leave the VA and feel like they're going to be former customers of the VA. And we want to re-engage those people. We want to sort of learn from them and then figure out what is the design of care that results in people not feeling that they have to leave us. And I think that could be a very useful nidus of interest and discussion in many aspects of the plan you included in terms of how we communicate, in terms of how we design research, and how we get advice.
Yeah, I think that's really good point that we hadn't thought about. And I think it does take extra care to locate those veterans and have them feel like they want to be included in this. But yes, they've already voted with their feet, and we should know why, right?
So I would say we have thought about this, and I have a list of questions I'd like to discuss at breakfast tomorrow about how to approach the veteran engagement panel. So I don't want to totally cut off all this enthusiastic discussion, but I hope you will come tomorrow so we can talk about our priorities and how we're going to think about this. And I think we had hope to maybe get some partner perspectives in here too. So we're just running short on time. So thank you for your enthusiasm for this topic, and please bring it to our early morning breakfast session.
Can I just say, I'm very sorry to say that we have a conflicting breakfast with all the veterans that we've brought to this conference tomorrow morning at 7. And I think those are the people that should probably go to this breakfast tomorrow. So I just want to
Why don't you come to our breakfast?
to do that, yeah. And I just, one comment, because I have some work with the Office of Patient Advocacy, and you can guess that opioid tapering is probably the #1 issue that, that they're fielding on an everyday basis. And so my question is, and we probably don't have time to discuss it, but I think it's really, the language that we're using is really important. And I'm interested in how you conceptualize the difference between long-term use, dependency, and disorder, because I think that people are labeled with opioid disorder, and it's a disorder that oftentimes the VA has created or the DOD has created, and they don't see themselves as that, and they leave.
Good question. Go ahead.
I will just add, that is exactly one of the topics that came out of the SOTA, and it is going to be, I think we're planning a Delphi study to help wrestle with this, because there are some people who don't believe there should be a separate diagnosis, and there are others who believe there should be, that there is this recognized, there could be a patient who was prescribed opioids, taking them just as prescribed, and now is on a higher dose and is having trouble tapering off. The way I was trained and the way I think about it, that person does not have opioid use disorder. But some disagree. We're going to get together and try to sort this out. But it's hugely important.
Since I'm going to ask a question, since we have the benefit of Dr. Cunningham here, could you tell us a little about what PBM needs from researchers around these issues?
Thanks. First of all, I'd like to say thank you for all of the help we've gotten. We've had a chance to work with several investigators in here, and a lot of the things that we had early questions about or on are starting to be answered. There are different arms of PBM. Clinical Pharmacy Practice Office has a very good relationship with investigators, academic detailing, as well as PBM Pharmacy Benefits Management. I think there are a couple of things that we need, because we see before. We often see things before research, and sometimes before the aggregate group of providers. One provider may see it, but not all of them. And so one of the things we saw years ago, I met Dr. Krebs, was an issue with methadone. And asked her, we did a quality improvement project, and she developed a research project to move further on. We saw a problem with discontinuation and reached out and started speaking with Dr. Sambrink. These patients aren't really discontinuing, they're leaving. And then some of those that are in here, how is the tapering? How we can look at a database, but we really don't know the nuances of that discontinuation and tapering in our patient cohort. So we're very interested in that transitioning patient, transitioning into the VA from DOD, transitioning into the VA because inappropriate opioid prescribing from peri-procedural occurrences, operations, other procedures. They're getting very large amounts of opioids. That initial problem starts prior to them coming in and continues. Or they may be a dual care or care fragmented patient, and they're getting their care outside of the system, and it's bleeding into our system, and our providers are taking care of it. And I think we need to look more at dual care fragmentation research, one, the transitioning patient in and out, and then another area I think we need to look at is use of other medications. We frequently will surveil medications. I saw propoxyphene drop, tramadol increase exponentially. I saw opioids decrease, gabapentinoids increase exponentially. What else am I seeing increase exponentially? Psychostimulants. Should we be doing other work? And so reaching out to us to kind of ask us, what are you seeing? Versus, do you think this is a good project? And I think that will help us a lot more as well.
Thank you. That was terrific. Thank you. So we have a few more minutes left, I think, so we can maybe have a few more questions, comments, or sharings from people. We get some new voices in this conversation. Okay, here we go.
So kind of tagging on to that issue of the veterans that leave, my question revolves around the links between PTSD, trauma, and chronic pain. We know that patients with a history of PTSD are at risk for re-traumatization, and we also know that the VA is moving towards trauma-informed care. So maybe it's underneath some of these things that you were describing, but I was just hoping you could talk a little bit about where is the current thinking on assessing and addressing the impact of prior trauma and on potentially doing more promotion of models of adaptation and resilience, either in the OUD treatment setting or being considered as a part of a prophylactic strategy for those at risk.
I see knowing nods.
That's a hard one.
Nancy, okay, we'll go here.
So this is something that people are becoming aware of in terms of thinking about. We know many of our veterans who have chronic pain, they have other co-occurring conditions, just as you said. PTSD, trauma are very prominent. And there is a push. One of the recommendations that has come out of the SOTA and something that is priority area is developing treatments that can treat these conditions at the same time, because they often will maintain each other and you often get poorer outcomes in your treatments. And so this is an area of focus. It's more so potentially an area of focus, at least starting out in women's health, because many of our women veterans have a trauma in their background, and it's a prominent problem. So there is training, there is a desire to increase these combined treatments, but we're not there yet, and we need to be moving there. I think it's a big area in psychological treatment and self-management treatments.
Yeah, thank you. So, this is actually really so important for us. On one hand, we need to look at patients who have comorbid conditions, and I think that's where we are in many ways. I think often lacking. You know, we look at a particular intervention, and we pick patients where this intervention may be most optimally applied, and we study the impact. But the reality is patients have multiple comorbidities, medical, mental health comorbidities. So we really need to see of how do we address those. And I think one of the emphasis, for instance, is pain and PTSD. It's so common. And at the same time, we see all the time that the pain care happens independent of the care for the PTSD. Right? So we need to define approaches, behavioral approaches that are truly addressing both conditions together in a combined approach, rather than somebody to CBT-CP for chronic pain specifically, and then maybe later for CBT-4I for insomnia, and a separate one that is for trauma. Can we bring those together and study? And it's going to be more efficient and we'll reach more people more appropriately. The other thing is that we have to learn about bringing different modalities together. So coming from different sides, increasingly in our interdisciplinary pain rehabilitation programs that we have in the VA, and we're lucky to have those really more than really outside of the VA system, is that we bring in physical therapy, restorative approaches delivered in conjunction, coordinated with behavioral approaches and integrative health approaches, and maybe chiropractic care and others, right? So that it's an integrated collaborative program that allows access together and where they inform each other, really like a block training, education, skills building, with everybody really building on each other as they move forward. And that can be probably, from what we know, but it needs to be studied, more effective, more accessible, and truly better for everybody, the system and the veterans.
I think it's actually a very nice note to close on. We're out of time, so I say thank this terrific panel. All right. Bravo.